So our next speaker is Kristen. Kristen, if you'd like to start sharing your screen. So Kristen Pogreba-Brown is from University of Arizona, and she will be presenting some slides on the US situation.
Good morning, everyone. Oh, I guess it's afternoon there. Well, it's good morning here. So I'm going to give a brief overview of Campylobacter in the United States, and I'm going to give a little bit of information about Arizona, specifically where I am. So enteric surveillance in the United States really, like many other places, works from kind of the grassroots level up. So we start at the local level where most of that data is collected, state health departments where it's collated, and then national at CDC where it is reported. Nationally, the CDC uses a system called FoodNet for most of their data. And that is really a sentinel surveillance system that represents about 15% of the US population. And it's an enhanced surveillance system for the areas that it represents, and I have a little map here. But because those 10 sites actually receive additional funding to conduct additional laboratory testing, additional surveillance, it's not always representative of what's happening nationally, but it's a good peek into what's going on with trends and other things. One example of that is with culture-independent diagnostic testing, which is more likely to be the sole diagnostic tool that we're seeing more and more for Campylobacter outside of these areas, because within these areas, they have requirements that cultures are submitted as well as CIDT testing, and that's not always true outside of these areas. And that has implications, as I will discuss in the next couple slides. So Campylobacter is, while not as high as some of the our European colleagues that talked today, is still the #1 bacterial foodborne illness in the United States, with an average of about 19.5 cases per 100,000, which is a 13% increase over the previous 3 years. And this was from the preliminary CDC FoodNet data from 2019. And the CDC found that CIDT accounted for about 42% of CAMPy infections, and only about 2/3 of those had a culture attempted as well. In Arizona, where I am, which is not a FoodNet site, in 2019, we had a 25% increase over the previous 3 years. And Arizona has historically had a little bit higher rates of Campylobacter than the rest of the country. We have about 22.5 cases per 100,000. We've also seen historically more higher rates in Hispanic or Latinx populations, children under the age of 5, and more often those are in younger boys. One of the things I wanted to talk about, so I actually neglected to introduce myself and give my background. So I'm an infectious disease epidemiologist at the University of Arizona. And my team has been doing Campylobacter interviews with state and county health departments for about 15 years now. And one of the things, like many other people who've alluded to, is the impact of the pandemic and how that has impacted surveillance for other diseases. So in looking for the 2020 data, you, at least in the US, you're going to keep looking for a while because it's simply not there yet. The vast majority of epidemiology programs at local and state health departments directed almost all of their infectious disease staff to work on COVID. So I've worked with infectious disease epis for many years. And for instance, my team, which does the vast majority of the Campylobacter case investigations for the state of Arizona, we were directed to decrease from our normal amounts to only do 10% of our surveillance. We had 90% of our cases were lost to follow up, because we ended up also getting directed to do COVID investigations. So my team has been directed to do almost 30,000 COVID investigations in the last 18 months or so, 15 months. So that's going to have a huge impact on the surveillance and the case rates that we're seeing with CAMPy for the last year and a half or so. Some people have actually tracked this to look and see what the impact of the pandemic has been on enterics have been reported. And we've actually had a debate within our own group as to whether or not we were going to see that go up or go down. In the UK and Israel, they found decreases in the amount of Campylobacter cases that were reported. It was about a 30% reduction at their peak. Korea actually found a small increase. And in the US, we're still not sure because the data hasn't been finalized yet. But I think it's probably going to be a combination of the two. I think we're going to have some that are going to have less disease. So we have about 20% of the cases in the US are due to travel. So when Campylobacter is synonymous with travelers' diarrhea, and all of us traveled far, far less in 2020 and probably 2021 as well. We have less travel, we had less events, as someone else alluded to with the chicken pate, less dining out, but we also had less reporting. So COVID had created huge burdens on the healthcare systems around the world, and as we indicated, lockdowns. And so people were fearful of seeking healthcare. So the general trend of Campylobacter in the US is it is continuing to increase. It often before used to jockey back and forth between Campylobacter and Salmonella as the #1 cause of bacterial foodborne disease, but Campylobacter has been holding steady as the #1 cause for the last several years. We have seen an increase in ciprofloxacin resistance over the last few years. We're also seeing increases not just in overall trends, but in specific groups. So in the US, we're seeing increases among some of our elderly populations, certain regional increases. So some of our southern states are having higher increases. And then, as I mentioned, we have ethnicity differences that we've seen for a long time. And one of the questions that we have as epidemiologists is whether or not this is a trend because we're, again, seeing more disease, or is this simply surveillance bias? So we know that CIDT makes it easier for clinicians to get answers quickly. So it's being utilized to diagnose CAMP far more often than we were seeing before. But we are also seeing more outbreaks, more large outbreaks. So again, I think we are catching more disease than we would have caught, but I also think we could make the argument that there is also more disease. So one of the biggest outbreaks that I'm sure this group has heard ad nauseum is the outbreaks associated with puppies in 2016, really through 2019 with multiple. And then raw milk outbreaks always happen. We've had one with muddy races. People like to do cross-country races. And then of course, poultry and untreated water are a common source. So one of the challenges, I guess, with public health surveillance for Campylobacter in the United States is that it is a changing landscape. So in 2007 and 2018, PulseNet, which for many, many years used pulse field gel electrophoresis, moved to whole genome sequencing. The problem is that not all the labs were as prepared to move to that as they could have been. And so at least I know that locally we had the mandate to move, but not necessarily the resources to do it as quickly as they would have liked. And the number of Campylobacter isolates analyzed through this method is not reported yet. So CDC has been focused mostly on Listeria and Salmonellas, and there's not as much focus on Campylobacter. And as many of you know, working in the lab with CAMP, it is a challenging organism to work with. And so it's important that in order to get the whole genome sequencing that we get the cultures. And because of CIDT, that's not always the case. And in local jurisdictions, you have to have it written into the local jurisdiction that healthcare providers submit a culture, not just a test. And so not all of the jurisdictions have caught up with that rule. So again, it has some benefits and some drawbacks, kind of as I mentioned here. So some of the research opportunities for those of us, I say who are stubborn enough to continue to work with Campylobacter, our team looks at a lot of the long-term sequelae associated with Campylobacter. We've known for many years a lot of the acute outcomes But there's a lot of research opportunities still. So with the exception of GBS, most of these, such as reactive arthritis and IBS, still have a lot of the incidence of these outcomes are still being investigated and debated, and the biological mechanisms are still under debate as well. So our team is focused mostly on IBS, along with there's another team out of Minnesota with Mayo Clinic who is doing that as well. And it's particularly challenging. So we have, if you work with health departments, you can, our team has early access to cases through public health case investigations, but it is challenging to get viable samples because we don't have one system or one laboratory that necessarily collects them all. You have laboratories all over that collect samples. And so being able to get those in one place can be difficult. Having willing participants, like all epi studies, people who are very sick are often more likely to participate. So you need to have incentives for everyone. And that really just leads to funding and grant funding. So being able to have funding for this kind of research is challenging, particularly in the US, where we have NIH who wants to point back to FDA and USDA wants to point to CDC, and CDC who wants to point back to NIH. And so it is challenging to do this type of research because nobody's exactly sure where to put the foodborne diseases when it comes to research. So I'd like to thank my team and collaborators, and I work with a lot of people at the health departments, along with University of Arizona, where I am, and University of Colorado, Elaine Scallon, and University of Nevada, with Dr. Mark Riddle. So, and I'll be happy to take questions after.
Thank you very much, Kristen. A great talk, and it just keeps us moving along.